my three panelists. They were fantastic. I think they have a lot of information to share, but you or people in the webinars have questions. I will take 2-3 questions.
Much for wonderful presentations. Each of you mentioned focusing specifically on children and families with special needs, along with your universal child development programs. And I wondered if you could tell us a little bit more about the particular challenges that you face with linking specialty care for mental illnesses and developmental disorders or developmental delays into the universal programs.
Gary?
Gary Darmstadt with Gates Foundation, a forum member. I wanted to hear a little bit more about the community performance indicators that you have in Chile. We hear a lot about parent-child interactions, but how families are interacting with themselves across communities, I think, is super interesting. I'd like to hear more about how you go about monitoring that.
Buenos días, Martín Benavides de Grade. Muchas gracias por las presentaciones.
Very much for your presentation. I think one of the most difficult topics when it comes to deploy these programs is the execution capacity we have at the local level. So I want to know from you, how do you do to generate incentives which are appropriate to keep local and regional level with good stuff that may put into practice all the programs you have created? Thank you.
Special needs, how to manage that. The second on community performance indicators, and the third on incentives for the local capacity to work properly. Paulo, do you want to start?
Bom,
I think that what is important and what differentiates what we have been planning, that is to do home visits using health agents, and what sets it apart from other programs that inspired us is that the Infância Melhor program in Rio Grande do Sul inspired us. Some other American programs, such as the Family Partnership and Cresce Contigo in Chile, have inspired us. But when we look at the scientific literature and we see what community health agents can do in home visits, we see a bit of confusion. Sometimes in some countries the health agents are people from the community, they are volunteers. So it's the same expression, but our health agents in Brazil, they are health professionals. Very recently, Professor Jack Shonkoff from the United States, one of the greatest authorities to talk about the damaging effects of stress in early childhood, he talked about the impact of this type of visits on these children with mental health problems, families with mental health problems or drug abuse. And he brought evidence that even when you have nurses doing these visits, the results are very poor. Our pilot projects will either give evidence for or against that in Brazil, health agents have behind them doctors, physicians, nurses, dentists, people specializing in health problems, professionals. So in the the health agents, they can resort to the center of psychosocial attention where they can find all the professionals they need to help the families. So there are people within the health sector who can support the health agent, and we also can rely on intersectoral people to help health agents. When health agents monitor a family, they are under the supervision of a nurse, and they can sit with a social assistant assistant of the district. They can sit with the teacher of a school, and they discuss the story of that family. So it's the same family who is being monitored in health, in education, and in social services. So we have been dealing with children with delays in development and with families where there is mental health problems. And the health agents can rely on all of these professionals. And how can we foster the development of local capacity? This is one of the biggest challenges. When we established the pilot program for Fortaleza and São Paulo, we established the backbone of the program, but the program is being adapted, and we have to maintain some key criteria in the municipalities of Fortaleza and São Paulo. Brazil needs to invest more in health so that we can ensure that people receive healthcare, universal healthcare. And in order to implement such a new program, we have to increase the funding to train people. Once this program is expanded countrywide, we will have to think about an incentive for municipalities to implement the programs. The funds and the resources that we have today are not enough.
Thank you very much for your questions. Of working with mental handicapped children, we have a standard, the standard behind Chile Crece Contigo program, and we have some rules there about the technical assistance for all the children with some sort of disability and which are in the most vulnerable part of the society. So we identify these children and they are sent to the institutions we have in Chile. On the other hand, we have some actions in the kindergartens and in the schools. We have some programs in place, and the idea is to encourage the inclusion of these handicapped children to the kindergarten, or disabled children to this kindergarten, and maybe deliver some equipment or some packages that allows them to work with the disabled children, that may allow them to approach to some of the disabilities that were identified. When it comes to the stimulation, we do some works in parallel. Chile Crece Contigo is a program which is not intervening directly on health subjects. So what we do is just promotion and communication and follow up to the families. When it comes to the indicators, I think it's a fantastic question, and it's a huge challenge, because in Chile our culture maybe is more family oriented, and we have lots of things to learn when it comes to community participation, as the way they do in Peru or Bolivia. Our indicators are more related with how the children is doing, the parental relations, the community network performance, and maybe empower families when it comes to their rights. And what happens in Chile as well as in other countries in the region, if a program ends because the government changes, the families are empowered and they know how to do what they have to. So When things are working fine, maybe they will be kept by the next government. But when it comes to empower the population, I think we still need to develop more indicators. When it comes to the local capacities, I think it's fundamental to use all the strategies that we have in our belts. We try to train our staff continuously. We encourage technical assistance of local and national groups in different levels. We have things such as the document when cheating is cool. Cheating in this regard means to copy what someone else is doing, so I think it's very interesting. So we ask people to send good ideas, good practices, and we try to select them and put them into a book and send this book to somewhere or to some other groups with the best practices. And what we try to encourage in this moment is to acknowledge their work, because they feel their work is being acknowledged as is being published in a book. So it's a nice way to encourage and recognize what they are doing in the local level. We try to promote some work or some meetings that are within a regional level, bringing specialists from other parts of the country and from abroad. We are trying to improve our work conditions. I think we have a long way to go yet on those, because professionals working on ECD are not very well paid, and their contracts are not the best for people who work with the most important asset of a country. And I think we base our work all the time in volunteers and professionals that work with scarce resources, and I think we need to develop more their conditions and improve their contract terms, and maybe understand that this is a job that should be well paid. With this, I mean that we have many areas to work. Not all of them are financial or economic, but I think it's important to understand them all, because human resources are crucial when it comes to achieving our goals for a policy like this.
Das crianças com algum atraso ou alguma deficiência, o Primeira Infância também trabalha desde que
or disabilities. Primeira Infância works with a larger network of care. In the municipal team, these cases are studies, and the team then, especially the health team of that area, relying on different centers, they receive orientation on how to conduct the visit and how to work with the family. And we have been seeing very good results. But the most important thing is to work in a networked fashion. It is very difficult to work alone with just with any family, and especially with families where there are children with disabilities or with mental problems. The program was at first conducted as a standalone program. It is an exercise that we have been doing for 4 years to link what we have been doing together with primary health care. So the health agent and the health professional are now in charge of taking care of these families. And as regards the incentives, when the state implemented Primeira Infância, early childhood in the municipalities, they decided to give training to the municipalities using a state team, and then also there is a funding mechanism that cascades resources and funds from the state to municipality according to the number of visitors, their workload, and so on. This transfer of funds goes from 500 to 1,000, depending on the workload of each visitor. And the third commitment is to provide supporting material, orientation, guidance, material for playful activities that have to be conducted with the family. We then hold forums in municipalities and at the regional level. In one of these meetings, we focused on primary care and health in early childhood, and all municipalities showed what they were doing. And this was a sign of appreciation for the work that the municipalities have been doing. Temos uma
in Brazil, and he asks, how is the support offered by the tool, the SMS program, how is the support evaluated? And then we have another from Luciana from Cabo Frio asking, knowing the importance of healthy development of infants, not restricted only to healthcare, but in all areas, she would like to know in what is the frequency these visits are made to these families, and what are the known benefits?
¿Tres más? Ok.
Sí. ¿Se escucha? Sí.
Sí.
En términos de cómo hacer replicables.
To how to repeat these experiences in different countries, let's say in low-income countries and low-middle-income countries. What's your experience when it comes to the funding mechanisms and the indicators of cost effectiveness and cost efficacy? I don't know if you want to share a little bit about your experiences for those countries interest on large scale programs like this.
I'm
da UFBA e eu estou no momento no meio
of the University of Bahia, and I am conducting
I would like just to say something based on a question. What would be the limit of the...
Quiero saber cuál es el límite del agente comunitario para trabajar con los problemas mentales en la comunidad. Yo creo que la idea de intentar desarrollar
the health program, I feel that in Brazil we don't know yet what is there, and we also don't know how to provide the proper care. And I think the main thing is to find out what sort of suffering is there. Some of this would be dealt with CAPS, the specialized level. Some of this could be dealt at the primary health care with the community agent. But I think that there is something that is not necessarily the specialized level, but that the community agent would not be able to deal with that. Because one of the main things in the community care is detection, early detection. There are few things that if they could be found out earlier, it's much better for the child. In this piece of research I'm doing, I hope in 6 or 1 year I could say something for you, Dr. Paulo. You know? It's just to find out the diagnosis, the psychiatric diagnosis that is there, because we are going to apply it as a survey. But I decided to do something in more qualitative way. That a sorte that we call Brincando em Família, where the children come there at least 4 times. And after this, a psychologist would say something about this child and their family. So I think we could figure out things that you can supervise the agent community person, and the things that can go to CAPS, and the things that the nurse or the team in the family health plan team would deal with. But I feel we need more data, we need to discuss it, to understand better what is there and how to deal with it properly.
And unfortunately, the last question to the panel.
Congratulations for the wonderful panel. I'm Euripides Miguel. I'm here from the University of São Paulo Medical School. I would like to have a question to Paulo Bonilla. Considering that you also have an important role in breastfeeding in Brazil, I have recently saw the work of Cesar Victora from Institute of Pelotas in a paper they are going to publish in Lancet. It's in press, showing that breastfeeding for women, for those who receive breastfeeding for more than 1 year compared to those who have only for 1 month, there is an increase in scholarity, IQ, and earning later in life compared to those who has not received breastfeeding. So I wonder if this would be an area for us to invest more in terms of public policy. And another for Eliese. Eliese, nice to meet you. Eliese, I wonder, we have some data showing that nurse-family partnership programs for people, women at risk, adolescents, poor, pregnant, and that conditions. For some people, for those people, nurse, when the nurse has a more important role, they have a better benefit compared to other professionals. So I wonder if you have it's amazing this universal program that you guys developed in Rio Grande do Sul. But I wonder if you guys are thinking about offering something more special for these very high-risk women.
I leave the questions to the panel.
Bom, em relação...
Con respecto a cómo se debe evaluar el programa.
Regarding how to assess the program, there's work that we're developing in the Amazon region, in the Amazon local communities. It's more advanced than the pilot that we've been running in São Paulo and Fortaleza, and we've been learning a lot from it. And the discussion with Yannis here from the Funding Foundation have been very rich in this sense, from ensuring the indicators of management that prove the intersectorial relationship that we want to have, at least the involvement of health, education, assistance. If we can involve culture just like they do it in Cuba, that would be great. If we can involve other things, wonderful. But health, public assistance, and education are at least the very minimum. Another very important indicator has to do with the capacity for the basic family health team. Basic indicators that assess this involvement and the capacity of the community before and after, involvement in discussions of these families, for example. And finally, the discussion of family competencies. That's very important. And we've been working to follow the indicators, so before and after. Did this family used to play with the children before the process? What about now? How, after the process has been deployed, do they play with the children or not? Did they used to tell stories before going to sleep? How's it now? So very simple things that even in a small community in the Amazon region could have an impact. Finally, the evaluation of community competencies. This is very important. I think we need to explore this more. And health agents can help us do this. So I don't think we had been discussing this. This debate brings this point. It's an alert, a wake-up call for us to think about community indicators. In terms of the evolution of children, we are trying to work with something that is already embedded in the life of health professionals. The markers of development that we have in the children's health booklet. All children in Brazil have a booklet when they are born at the maternity, and this has some development grades. We're trying to use this tool better. Finally, I'll have to select here so that I can answer most of the questions. But the frequency of visits, that's key. Evidence shows that if we start early with children right at the very first months of life, and preferably during pregnancy, is key. And the intensive, I think Leah is going to talk about this, but we have a work with weekly visits. This is not going to be possible for all children. So we think about this work with a score of risk criteria where we can ensure weekly visits for those children who are more vulnerable, children with different risk indicators. So they're extremely poor, they are focus of Bolsa Familia. This doesn't necessarily require intensive visits. What we need is a score to separate the children that are more vulnerable and those who are less. Finally, breastfeeding is one of our focuses. We have a line of action, this has been for a long while in the ministry already, which is called, or was called, Breastfeeding Brazil. And now we have incorporated this with health food. So our professionals of basic care, doctors, nurses, are prepared to deal with breastfeeding handling, and with health food, complementary health food, because sometimes we have even more problems when food is introduced, because a lot of inadequate foods are introduced after 6 months. So the evidence shows that these units from the basic unit of health sometimes the impact is of a very short term. In other words, after a few months, children go back drinking lots of soda and eating sweets and so on, just like children who were not the object of any work. So our effort now is to integrate this content of breastfeeding and health eating during the house visits. So this can bring, we believe, and this is what the studies will show or not, a greater possibility of changing the eating habits in these families. So when the health agent is there at the family and sees the Coca-Cola in the bottle to feed the child, this is a different situation. So they need to discuss with the families how to deal with this. This might bring a greater impact than just working within our units of health.
One in Chile, we don't work with community agents. Therefore,
profesionales o técnicos para
have technicians and professionals. And for this, there are other demands. And in the case of the replicability of the experience, we have a number we have experience of cost effectiveness and how it costs, and we can transfer this to dollars. I would just like to say that we've had the pride and challenge to show other countries what we have done well and wrong. And we always say that we don't see the content of interventions. What we try to do is to show the management model. What the management model shows us is to follow up the trajectory of development, a wholesome view that sees health, education, social protection, and other interventions that contribute toward the development to boys and girls, following a network schematic and intersectorial schematic. So if the program and we have to give equipment to boys and girls that are born in public hospitals or to deliver breastfeeding. The challenge is the same in all of this. What can change is the benefit. What can change is the content. The idea is how we work intersectorially that is more difficult. Our model, when we talk about replicability, what we want to show is how we build bridges that allow us to talk and to help, and how to work with health, education. This is why in Chile, policy is not coordinated by health or education. It's coordinated by a small ministry that is the social development ministry, because when you have a more sectorial view, this focuses both on education and health. But we believe that this is an important management model that is important to share.
I'm also going to pick a few of the questions. Among them, the visits are made weekly from pregnancy up to 6 years of age. So if there is a pregnant woman or children up to 3 years, the visits are weekly. And with the pregnant women, we have a work that is connected with basic health care. So they have meetings every 15 days. There are meetings with these pregnant women, coordinated either by a nurse who is a representative of PIN or someone to that effect. So it can be a nurse who's heading that specific team or that coordination of the municipality, and the meetings are held with these women, with these girls sometimes. And the visits then are paid to the families. And with children between 3 and 6, we also have weekly meetings at the community level. Families are invited to participate at certain dates and times. People get together with this monitor, this person who carries out this work to follow up the visitors. So we have two types of services: pregnant women and up to 3 and 3 to 6. Talking about replicability, yes, I think the effort is to see childhood in a shared way by different areas. I think this is the great legacy that we have been making more and more important at this stage, at early childhood. Nothing should be done in an isolated way. So we need to make people understand that we need intersectorial care, a network of care. Eu gostaria de concluir dizendo muito obrigada, Andrea, Paulo.
I think this has been a very rich conversation. I don't want to take much time just to say the IDV is extremely happy of being a forum member and a sponsor of this initiative. And I think as a forum, just synthesizing and putting these experiences together in the notes of this workshop is going to be extremely, extremely useful for some of the countries, at least the IDV is working with. And if any of the panelists would like to have half a minute final remarks, please.
Panelistas quiserem falar alguma coisa a mais, meio minuto, tá?
Dos grandes desafios que nós temos é
One of the great challenges we have is to monitor these experiences to promote child development. PIN has been evaluated by some, but we need for it to be better assessed. For the pilots that we're developing vis-a-vis Fortaleza, in addition with a partnership with the Federal University of Ceará, we have a partnership with the Inter-American Development Bank, IBD, because we want to engage in a research that can assess this impact in Fortaleza. But in this forum, with so many important players, I would like to say that we need more support. So PIN Rio Grande do Sul is a state public policy which hasn't been studied enough. It's a very important field for study. And even in São Paulo, the largest city in Brazil, we still don't have a partnership to assess and to monitor this pilot that we're going to start in the city of São Paulo. So I'd invite you all. We need to evaluate and assess the experiences in Brazil. You're all invited to collaborate.
I'm going to be very brief. For Chile Crece Contigo, the great challenge, and we are self-critics. We criticize ourselves constantly. We always see how we can improve things, what is missing, and we focus on our local governments. In the case of the Chile, every 4 years we have elections. This is democracy. We want to have democracy, but this means that the team's priorities change, and this means that we need support in order to sensitize and to work with local governments that change. Intersectoriality, you don't attain this from day to night. Authorities change, political priorities change. So we have an intersectorial working model that is clear. And this is a challenge that we're dealing with. And of course, human resources, I insist on how important it is to work with human resources of all levels. And as Paulo said, Chile Crece Contigo, and Chile is considered like a country of high income, but there is still a lot to do. We still have to work more with the academia, with communities. So if anybody wants to contribute, you are welcome. If you want to come and see what we're doing and give us feedback, we would be very thankful to you.
Once more, thank you very much. And really, PIN needs to be more investigated. We have a number of papers, master's and PhD papers, but these are isolated. And we had this application together with Canada and with Maria Cecilia Foundation. We analyzed the promptness of children when they start school. So going through primeira infância, the early childhood development, with and without stimulus. And in this research, we detected that children, when they go through these programs, they have a different level of potential. The boys, especially, had a markedly different result in terms of their promptness when they arrive at school. But this was one research. We're now starting another one with Getúlio Vargas Foundation. We also there analyzed all the levels of PIN at the local, state, and federal levels, and the families receiving the visits. We're waiting for the results of these studies. But I think it's very important to research and study, and you're all welcome to work with Rio Grande do Sul. Thank you very much.